Hey guys, welcome back to my channel, The ENT Resident. Today we'll be discussing part 2 of nasopharyngeal carcinoma. In my previous class, I discussed about the etiology behind nasopharyngeal carcinoma, what is the pathology, what are the clinical features you see in those patients, and how does the carcinoma spread. In today's class, we'll wrap it up by discussing about the management of nasopharyngeal carcinoma. You can also purchase my notes now. I have added links in the description. Okay, so let's get started. So, whenever we say management of a disease, we divide it into two parts. How do we investigate the disease? And then, once we have confirmed our diagnosis, how do we treat the disease? So, let's first start with investigations. So, our first primary goal over here would be to visualize the disease, to find out what is the extent of the disease. To perform that, we have to perform a nasal endoscopic evaluation. So, we'll introduce a endoscope into the nasal cavity and reach the nasopharynx, and we'll inspect the nasopharynx, try to see what is the location of the tumor, how far is it extending on all of the sides, and if required, we can even perform biopsy of the area. Sometimes we know that the most common presentation of nasopharyngeal carcinoma is actually a cervical lymphadenopathy. So sometimes there may not be a discernible growth in the nasopharynx, but the patient has come to you with a metastatic lymph node with an unknown primary. Even in those cases where we are not seeing any particular mass in the nasopharyngeal area, we can take a biopsy from there, and that will help us confirm whether the primary is in the nasopharynx or not. So, we'll definitely perform an endoscopic evaluation to see the localization and the extent of the tumor. And second most important thing to do over here would be to perform biopsy. Now, biopsy is the gold standard in diagnosis of nasopharyngeal carcinoma. We can either do it under local anesthesia or general anesthesia, depending on case to case. So, where would we take the biopsy from? Usually, it is taken from the roof of the nasopharynx, central area of the nasopharynx, mucosa of both the fossa of Rosenmuller. We know that the fossa of Rosenmuller is actually the most common site of development of nasopharyngeal carcinoma. If, as I've mentioned before, if the growth is not visible, but we are highly suspecting the case to be that of nasopharyngeal carcinoma because of the presence of metastatic lymph nodes, in that case, we can take multiple blind biopsies from different sites over here. So, biopsy is our gold standard over here. Next, we also learned about how the fossa of Rosenmuller lies posterior superior to the eustachian tube opening. So, a lot of the times, because of the growth, it can lead to blockage of the eustachian tube, hence leading to eustachian tube dysfunction and leading to development of serous otitis media, which is unresolving. So, because of that reason, we should definitely take a baseline audiogram for the patient when they come to you. This will help in diagnosis of the serous otitis media, and not only that, it will also help you in determining the side effects of chemotherapy and radiation therapy in the development of sensory neural hearing loss as a side effect. We'll talk about the treatment in a little bit, but our mainstay of treatment is in nasopharyngeal carcinoma is radiotherapy along with chemotherapy at times. So, establishing a baseline audiogram is very important. Next, let's move on to the imaging. Now, what all different imaging would we do? So first, looking at contrast enhanced CT scan of the nasopharynx and neck. This will help us in revealing where is the primary growth, what is the extent of the growth, is there any involvement of the skull base or the clivus, if there is any extension to the parapharyngeal space, the retropharyngeal space, and the intracranial region. And we'll also be able to see whether there is any neck node involvement. So, if you remember about neck nodes, can you tell me what is the first node in the neck to be involved? The first node to be involved is the retropharyngeal node of Rouvier. Can you tell me what is the most frequent node to be involved? That is the level 2 lymph node. So, the CECT of the neck will also help us in finding out if there is any involvement of the cervical lymph nodes over here. If you look at the image over here, we can see that this is the nasopharyngeal carcinoma over here. The second image over here is showing retropharyngeal lymph node involvement. Here, in the third image over here, we can see that there is orbital involvement along with infratemporal fossa involvement. We have discussed before how there is different directions of spread in this carcinoma. That is actually a very important question. It'll come as a long question for you, and if you end up getting a case of nasopharyngeal carcinoma in your practical exams, that will also be very important to know what are the different directions it can spread, and hence what are the different structures, what are the that it can involve as a complication, and because of that, what are the symptoms you should be looking out for? Next, so this was about the contrast enhanced CT scan of the nasopharynx and the neck. In contrast, it will be a mildly enhancing scan. Next, the preferred imaging modality would not be CT scan, but rather it is MRI. This will help us in staging this disease. MRI is where we do MRI when we need to look at soft tissue. So, MRI is very good for soft tissue delineation. This will help us in understanding the extent of the tumor. Why do we prefer this? Because this will also help in better delineating the parapharyngeal extension of the tumor if there is any perineural spread and marrow infiltration. And not only that, MRI will also help you in differentiating whether it is a tumor versus any retained secretions in the sinuses. It will also help us in defining the limits of optic chiasma, optic nerve, brainstem. So MRI has multiple roles over here because all of these soft tissue gets involved in as the disease progresses further. So MRI will help us in delineating that, and it is also better than CT in monitoring the disease as well. So not only in diagnosing the disease and finding out the extent of the disease, it will also help us in monitoring after treatment has been done, and also find out whether there are any recurrent tumor is left or not. If you look at the image over here, we can see this is the nasopharyngeal tumor over here. So that's about MRI. Now, next, coming to ultrasound. Why would we need ultrasound? So, as I mentioned, because cervical lymphadenopathy is a very common feature over here, ultrasound will help us in finding if any neck lymph nodes have been involved. And along with this, ultrasound can also help you in taking taking a sample for FNSC from the neck node if there is any such involvement. So, doing the ultrasound along with FNSC actually improves the accuracy of the FNSC. However, disadvantage of ultrasound would be that the accuracy will depend on the person who's operating this, and images and information acquired cannot be fused with other cross-sectional images. That is why the role of ultrasound is limited to just the neck lymph node diagnosis. Next is PET scan. Now, PET scan is important to find out any distant metastasis presence in the case or not. In this case, 18 FDG is the most frequently used isotope. This will help us in finding out distant metastasis along with the extent of locoregional disease. And not only that, it will also help us in finding out residual disease and recurrent disease after treatment is done. So that is how PET scan is important. And bone scan will also help us in finding out whether there is any bony metastasis. We have heard about like how hematogenous spread can involve the bones. So that is why this is important. Even the lungs. For that, we can either perform a X-ray chest or the CT chest to find out for lung secondaries, and a CT scan of the abdomen or the ultrasound of abdomen for secondaries in the liver. So that's all about the different imaging that we can perform in a case of nasopharyngeal carcinoma. Next is FNC of lymph node, which we already discussed. This will help us in finding out whether any neck node is involved. And we can also perform an IC staining of the EBV RNA genome, and this will help us in giving a definitive diagnosis. Next are the different lab tests. Now, there are certain lab tests related to Epstein-Barr virus that we can perform over here. So, the first one is Epstein-Barr virus antibody serology. So, we can find IgA antibodies against two antigens. One is the viral capsid antigen and one is early antigen. Now, the viral capsid antigen is sensitive but not a specific tumor marker, whereas early antigen is specific but not a sensitive tumor marker. So, these two are actually very commonly used tumor marker that we use in order to screen for nasopharyngeal carcinoma cases. Other than this, we also have the EBV nuclear antigen 1. And looking at titers of antibodies, if we have serum Epstein-Barr virus IgG titers, IgG will be indicative of prior infection, whereas IgM titer would be indicative of recent infection. But these two are not useful in screening. For screening, mostly we use these antigens over here. So this is about the antibody serology. Next is plasma Epstein-Barr virus DNA titers. Now, DNA titers, this is uh, uh, not only useful as a diagnostic test, it also helps you in screening for cases of nasopharyngeal carcinoma. And the third use over here is a prognostic use. It will help us in following up after treatment. So, EBV DNA titer is a tumor marker that is very important in case of nasopharyngeal carcinoma. So, first thing we have to do is first of all establish the threshold level of plasma Epstein-Barr virus DNA in the patient. This will help us in determining whether it is a case of nasopharyngeal carcinoma or if there's just very low levels of DNA due to activation of the infection. So this has helped us in diagnosing. Coming to prognostic uses, if we find that there is a high level of Epstein-Barr virus DNA before the time of treatment, that will correlate with the fact that this has a very large tumor load, and hence this is probably a more advanced stage of the disease. So this is about before treatment. Now, after treatment has been done, the Epstein-Barr virus DNA levels start to rapidly decrease, and they go down to either becoming undetectable or they have very low levels within as short as 1 to 2 weeks after the completion of treatment. However, if say that levels have not decreased, if we are finding there is a persistently elevated level of plasma EBV DNA titers after treatment has been done, that will be indicative of a persistent locoregional disease or the development of distant metastasis. Another pattern that we may see over here is that after treatment, there is an initial drop of the DNA levels, but right after that, there is again a progressive rise. This will indicate towards tumor recurrence. So the tumor did respond to the treatment that has been given, but right after that, it again started rising. Therefore, it is a recurrent tumor over here. So all of these, you can see how this is helping us prognostically. So before we start treatment, we find out whether this is an advanced disease or not. Then we see response to the treatment. Sometimes there can be persistently elevated levels despite treatment. That means there is a persistent disease. But if the levels drop and they increase again after that, that is a recurrent tumor. So this you can see how plasma Epstein-Barr virus DNA levels play a very important role not only in the diagnosis and screening of the disease, but as well as in prognostic follow-up. Next is nasopharyngeal brushing for Epstein-Barr virus DNA. Sometimes we can directly detect the Epstein-Barr virus in the nasopharynx. This can be actually better than performing the plasma EBV DNA levels. They have a very high sensitivity and specificity. So that's all about the investigations we'll perform in a case of nasopharyngeal carcinoma. Now let's briefly talk about the staging of this disease. So we have the AJCC classification for nasopharyngeal carcinoma staging. So first looking at the T staging. So T1 is when the tumor is confined to the nasopharynx or it is extending to the oropharynx nasal cavity without any parapharyngeal space involvement. Whenever the parapharyngeal space involvement is there, it becomes T2. So along with parapharyngeal space involvement, there can be infiltration of the medial pterygoid, lateral pterygoid or prevertebral muscles. T3 is when it starts invading the bony structures of the skull base, the cervical vertebra, pterygoid structures and paranasal sinuses. And lastly, T4, which is the most advanced one, is when there is intracranial extension, involvement of cranial nerves, hypopharynx, orbit, parotid, and or infiltration beyond the lateral surface of the lateral pterygoid muscle. Looking at the N staging, N1 is when there is unilateral metastasis in cervical lymph node and or unilateral or bilateral metastasis in retropharyngeal lymph node. Size is usually less than 6 cm and limited to above the caudal border of cricoid cartilage. N2 is when there is bilateral metastasis in cervical lymph node, still 6 cm and less above the caudal border of cricoid cartilage. And N3 over here is metastasis in cervical lymph node. Here the size is more than 6 cm and or extension below the caudal border of the cricoid cartilage. So that is about the the AJCC staging for the tumor of nasopharyngeal carcinoma. And M0 is, we know that M0 is no distant metastasis and M1 is when distant metastasis is present. And this is the staging of the nasopharyngeal carcinoma. Coming to differential diagnosis, there can be multiple differential diagnoses over here because of common symptoms and signs presented by the patient. It can be an inflammatory disease like rhinosinusitis or nasal polyposis. It can be some infection involving the nasopharynx like a viral infection or tuberculosis. And it can also involve other malignancies like TNK lymphoma, mucosal melanoma, sinonasal undifferentiated carcinoma, and olfactory neuroblastoma involving the nasopharynx. Now, last of all, let's talk about the treatment of nasopharyngeal carcinoma. So first we'll talk about the primary treatment over here and then we'll move on to salvage treatment. Salvage treatment is when there is a persistent or a recurrent disease. So starting with primary treatment. Our main modality of treatment over here is radiotherapy. This is not surgery because this is actually the nasopharynx is actually a very difficult site to access, and also this is a very radiosensitive tumor. So the non-keratinizing subtype of the nasopharyngeal carcinoma is a very radiosensitive tumor. So therefore, radiotherapy ended up becoming the cornerstone of loco-regional treatment of all stages except for the stage when there is distant metastasis. So distant metastasis, whenever there is distant metastasis, the stage becomes 4C. That is a different one. But from stage 1 to stage 4B, our main modality of treatment stays to be radiotherapy. So if it is just stage 1 or if it is a low risk stage 2, these are the early stages. In that cases, we just give radical radiotherapy alone. But if it is anything other than that, if it is a stage 2 with a high tumor load or a stage 3 or stage 4, in that case, radiotherapy is combined along with chemotherapy. So nowadays, the main modality over here is intensity modulated radiotherapy. There are some different target volumes that you should know over here. There are 3 volumes over here: gross tumor volume, clinical target volume, and planning target volume. Now, what is gross tumor volume? Gross tumor volume involves the tumor which is present in the nasopharynx and any enlarged retropharyngeal neck node which is more than 6 mm or lymph node with any necrotic center. So that is what gross tumor volume involves. Clinical target volume is the gross tumor volume along with the subclinical disease spread that has happened around the nasopharynx or the neck. So clinical target volume is further divided into CTV1 and CTV2. CTV1 is gross tumor volume along with the margin. The required radiation dose over here is 70 gray. Whereas CTV2 is which involves CTV1 along with the margin and areas of which are at risk of microscopic involvement. What are these areas? These areas can be the entire nasopharynx, retropharyngeal node, skull base, clivus, pterygoid fossa, parapharyngeal space, sphenoid sinus, posterior part of the nasal cavity or the maxillary sinus, and pterygopalatine fossa. These are all the areas which are at risk of microscopic involvement. So these areas are also involved in CTV2. In CTV2, at least 60 gray is given as a treatment. And the third volume over here is the planning target volume, which is clinical target volume along with a margin to allow for any possible error that can happen because of the daily positioning and treatment of the patient. So these are 3 volumes that you should remember in relation to radiotherapy as a treatment for nasopharyngeal carcinoma. Now, coming to chemotherapy, nasopharyngeal carcinoma is also very sensitive to chemotherapy. So, sometimes we use concurrent cisplatin during the time of radiotherapy and then follow it up with adjuvant cisplatin and fluorouracil. This is usually done in advanced stages, which is stage 3, stage 4, and stage 2 with a high tumor load. In these cases, we give concurrent chemoradiotherapy and following it up with adjuvant cisplatin and fluorouracil. So the most common agent over here which is used is cisplatin. The dose of cisplatin would be a weekly dose of 30 to 40 milligram per meter square or a 3 weekly dose of 100 mg per meter square. So what we need here is a total dose of 200 milligram per meter square to benefit survival. So, if after primary treatment, patients end up with recurrence of the disease, they are exposed to cisplatin as well as 5-fluorouracil. Other than this, there are some newer agents that are also used nowadays, like taxanes and gemcitabine, which have been used in metastatic cases and recurrent cases. But however, the main therapeutic agent over here is cisplatin, and then followed by fluorouracil. So that's about chemotherapy. Now, this is what we have discussed so far is the primary treatment of nasopharyngeal carcinoma. Now let's look at salvage treatment. Who are the patients who require salvage treatment? These are patients who have recurrences after primary treatment has already been done. So we'll divide it into different parts. Now, say there is a local failure. In that case, we can do either radiotherapy or surgery, even for nodal failures. So first, let's discuss radiotherapy for the local failures. In these cases, we deliver it by the external beam radiotherapy or local brachytherapy. But the most important thing to remember here is a patient who has already been exposed to radiotherapy as the primary treatment. The limiting factor over here is to re irradiate the same areas because there are some vital organs involved over here, like the brainstem, the optic chiasma, and the temporal lobe. Because of this, we use 3D stereotactic radiotherapy and intensity modulated radiotherapy so as to reduce the dose and protect the vital organs as much as possible. The main radioactive sources used over here are iridium 192 and gold 198. This is suitable for tumors which are less than 2 centimeter in maximum dimension. The 5-year survival rate in this case is 50 to 60%. This was about radiotherapy for the local failures, local meaning the nasopharyngeal area. Now, say there is a nodal failure. This will also have radiotherapy and surgical treatment as options. So, in case of radiotherapy for the nodal failures, we here we will be seeing that patients who are coming to you with persistently large neck nodes 3 months after completion of the radiotherapy, they are considered as a case of persistent nodal disease and they are offered salvage treatment. So we use brachytherapy over here, but we can sometimes combine it with along with surgical resection of the nodal metastasis. Brachytherapy, why? Because this has a limited penetration and therefore it does very limited damage to the surrounding tissue. So, nodal failure cases, isolated nodal failure cases are only about 5% of cases. So, this was about radiotherapy being used as a salvage treatment. Now, let's look at surgery as a salvage treatment. So, if we had to look at surgery as a salvage treatment, we'll divide it into two parts. One is the local failures, meaning the recurrence in the region of the nasopharynx, and one would be the nodal failure, which is recurrence in the nodal areas. First, talking about the surgery for the local failure, here we have to perform a surgical resection of the nasopharynx as it is the only method of treatment for salvaging the radiation failures. Now, why do we keep surgery as our last ditch measure? Because nasopharynx is actually an area which is very difficult to access surgically, and most routes of access are very invasive. They require a lot of facial incisions or multiple osteotomies to be performed. That is why we try to treat it with radiotherapy. But in case if we do need to perform surgery, we do have a lot of surgical approaches over here. So, starting with our first approach, the inferior most approach where we are targeting the nasopharynx inferiorly. This is known as the transpalatal approach. This approach is actually very extensively used to treat local failures. The advantage being there is minimal bone removal over here, and we do not need any facial incision. Here we are approaching it through the palate inferiorly. So that is why we do not require any facial incision over here. But this also comes up with a disadvantage because we do not have uh, much of lateral access to the parapharyngeal space if we go through this approach. So that is the disadvantage of doing the transpalatal approach. And the second disadvantage over here is because we are approaching through the palate, therefore it also leaves behind a risk of development of palatal fistula. So this was our first approach. The 5-year survival rate of this approach is 52% and local control rate is 67%. Now we learned how the disadvantage over here is we have limited lateral access to the parapharyngeal space. To improve that, we have another approach which is an inferolateral approach. This is the transcervicomandibulo-palatal approach. So what we are doing here is that transpalatal approach, whatever exposure we are getting from it, we are adding to it a lip splitting mandibulotomy. So adding a lip splitting mandibulotomy to the transpalatal approach is improving our lateral exposure to the ipsilateral parapharyngeal space. We are getting a much wider view and access in this case. However, the disadvantage of this approach would be a significant long term morbidity because we are significantly disrupting the normal anatomy over here. So, this was our inferolateral approach, also known as the transcervicomandibulo-palatal approach. Next approach is our anterior approach, where we are going through the anterior aspect. This is known as the mid-facial degloving approach. Here, mid-facial degloving approach is very famous because here we do not actually give a facial incision. So we do not have a facial scar. Here we are lifting up the soft tissue from the mid face. So this is increasing our exposure of the nasopharynx, and we are performing a bilateral medial maxillectomy and a posterior nasal septectomy over here. So because we are approaching through anteriorly, here the risk of palatal fistula goes down. However, this also has poor exposure of the lateral area. We are not having enough lateral access over here. So to approach the lateral area better, we have another approach which is the anterolateral approach, and this is the maxillary swing approach. So in maxillary swing approach, we have Weber-Ferguson-Longmire incision. Now because we are giving this incision, we end up with a facial scar. Here we are basically swinging up the bone along with soft tissue of the mid face. So the advantage of this approach is that we are getting a wide exposure of the nasopharynx as well as the parapharyngeal space. But disadvantage is we are ending up with a significant morbidity because of the anatomy being disrupted. We have facial scar over here, and patient may even have trismus. The 5-year survival rate of this approach is 56% and local control is 74%. Another anterolateral approach that we have over here is the facial translocation approach. This gives us exposure to the infratemporal fossa and the masticator space, and the 5-year survival rate is about 48% and local control rate is 53%. Another lateral approach other than the one that we already studied so far, the anterior and the anterolateral approaches, this is a purely lateral approach, and this is known as a lateral skull base approach. The advantage of this approach is that we can access the middle cranial fossa over here, and this will help us in early identification and protection of the internal carotid artery. But disadvantage is there is too much mobilization of the normal tissue. So therefore, it ends up in causing significant morbidity of the patient. And because of this being a lateral approach, the anterior visualization of the nasal cavity and the paranasal sinus is very poor over here. So these were all the different approaches. The last one is the endoscopic approach. Now, endoscopic approach will help us in resecting the tumor which is confined to the nasal cavity, the paranasal sinuses, or the anterior skull base. Advantage here is that we are not damaging the normal structure of the facial skeleton and there is minimal loss of function. So, therefore, there is less morbidity associated with this approach. An extension of the endoscopic approach is something that is known as the Da Vinci surgical robot, which helps us in assisting a minimally invasive nasopharyngectomy. The advantages of the Da Vinci surgical robot is that this gives us superior manipulation of instrument in the tight space. It has motion scaling. It removes the impact of tremors. These cases usually have a shorter hospital stay and less blood loss. So that's all about the salvage surgery for local failures. Now coming to last part of it is nodal failure. So in nodal failure, the surgery that we'll perform over here is a radical neck dissection. Why do we perform radical neck dissection? Because we have seen how multiple neck nodes can get involved in a case of nasopharyngeal carcinoma. And the rate of extracapsular involvement is also very high in nasopharyngeal carcinoma. That is why the only salvage surgery we can perform over here is a radical neck dissection in case of a nodal failure. For advanced nodal disease, where the tumor has not only involved the neck nodes but it is also involving vital structures like the brachial plexus or the carotid artery, we do not perform a complete excision of these structures over here. We try to avoid it. In these cases, we do surgery with a very palliative intent. We prepare the patient for brachytherapy after loading of the radioactive source. So, this is how we uh, perform surgery or use radiotherapy as a salvage treatment in cases where there is persistent or recurrent disease. Next, last part of the treatment is if there is metastatic disease, how do we treat it? So, if we find that there is oligometastasis, the options over here would be either to perform surgical resection, radiotherapy, radiofrequency ablation, or radiotherapy. These are our three treatment options for oligometastasis, where we see 34% of patients come to you with metastatic disease with only single organ metastasis and 16% with a solitary metastasis at the time of diagnosis. If there is distant mets, we can also use chemotherapy. In that case, the treatment of choice or the drug of choice would be cisplatin along with 5-fluorouracil. And the usual overall survival in these cases is 12 months. And second line drugs involve gemcitabine, docetaxel, and capecitabine, and paclitaxel as well. So that's all about the treatment aspect of nasopharyngeal carcinoma. Our mainstay of treatment being radiotherapy, and in advanced cases, we add in chemotherapy along with it. So now after the treatment, how do we follow up the patient? So we have to follow up the patient by performing repeated endoscopy and biopsy of the nasopharynx to confirm the disease resolution after radiotherapy has been completed. So we here biopsy should not be done right after radiotherapy. We have to give it enough time for the radiotherapy to continue acting on the tumor cells, which will undergo apoptosis even for as late as up to 10 to 12 weeks after the completion of radiotherapy. So it is only after that we perform a biopsy of the nasopharyngeal area. And if we see that the biopsy is positive even at 12 weeks after radiotherapy, then we classify it as a persistent disease. What is a follow up schedule that we usually follow? Usually, for the first 2 years, we do a regular 2 to 3 monthly follow up. And then from the third to the fifth year, we see the patient for about 3 to 4 times in a year. And after that, we make it a 6 monthly or a yearly checkup. So that's how we follow up the patient after treatment. Coming to prognosis of the patient, if the patient has undergone early diagnosis and treatment, they have a very good prognosis. Lymphoepitheliomas have a better survival rate. The two main reasons over here for improvement in mortality in nasopharyngeal carcinoma cases has been the introduction of intensity modulated radiotherapy and concurrent chemotherapy. Last of all, the 5-year disease specific survival rates over here are stage 1 is 100%, stage 2 90%, stage 3 and stage 4A is 67%, stage 4B is 68%, and stage 4C is 18%. We can see how at stage 4C, which involves distant metastasis, the survival rate significantly drops to 18%. So that's all about the management of nasopharyngeal carcinoma. If you have any further questions on this, please note them down in the comment section and I'll get back to you. Thank you.